about update in the diagnosis and management of non-dysplastic Barrett esophagus. In Barrett esophagus, as we all know, there is extension of the pink salmon-colored mucosa into the tubular esophagus, and this is associated with the birth of 2.3%, and the EAT is much lower, around 0.59%. But if you look at the prevalence in those with GERD, that goes up to about looked at Barrett esophagus prevalence. None of them is of any high quality. This is our own study here where we looked at around 2,800 patients on .2%, and most cases were short segment Barrett esophagus, and we found only one case of dysplastic Barrett. But GERD symptoms are not very good predictor of Barrett esophagus, and if you are going to screen everyone for Barrett, the economic burden is huge, and even with the current guidelines, the cost effectiveness has been questionable. Many patients diagnosed with esophageal adenocarcinoma history of Barrett esophagus, that's around 10%. But if you look at all those diagnosed with early esophageal adenocarcinoma, up to 90% of them, they have endoscopic evidence of GERD at diagnosis. This is a more recent systematic review that looked at the prevalence of GERD, of Barrett esophagus in those with GERD is around 7%, and in those without GERD, around 2.2%. And when they limited analysis to population-based studies, the gap between those with GERD, those without GERD was much narrower, so 7.7% compared to 4.8%. A number of screening models have been developed, and these have been shown to be much more accurate compared to GERD symptoms alone, but they are not widely used in clinical practice. Barrett esophagus after sleeve gastrectomy. As we know, we are living in an era of obesity epidemic, and now our patients, they get endoscopic sleeve as the most common bariatric surgery, and those patients are at risk for GERD. DDW, the risk of de novo Barrett esophagus after sleeve gastrectomy was 6.8%. In GERD, up to 3%, but if you have GERD plus one other risk factor, that goes to around 12.2%. Family history has been identified as the most risk factor to be associated with a much higher risk of Barrett esophagus. In this review was 23%, but it was lower in other studies. A number of international societies have published guidelines to screen for Barrett esophagus. They have some variation, but they focus on patients with chronic GERD plus additional risk factor. For instance, in the most recent ACG guidelines, they recommend screening in patients with chronic GERD with 3 or more risk factors, including age, including capsular endoscopy, but with a very limited study at the present and not sufficient accuracy to be recommended for screening. But we have a number of cell collection devices, including the cytosponge, esophagocap, and EsoCheck. And now, in the most recent guidelines, the cell collection devices have been suggested as an alternative way to screen for Barrett esophagus in both the ACG and the ESG guidelines. Cytosponge is the most commonly evaluated cell collection device, and in the multi-center UK pragmatic study, where patients were randomized either to the usual care to screen for Barrett or to cytosponge by invitation, and they found that those randomized to cytosponge have a much higher prevalence of Barrett esophagus, although most of them did not really undergo the procedure itself. And those with a positive test, they have a 60% prediction to have Barrett esophagus. A most recent study looked at the endoscopy have been shown for a long time to have a very good correlation with standard endoscopy with regard to the diagnosis of Barrett esophagus. A number of limitations related to this that the patient may not accept doing it, and the image quality is inferior, and we cannot obtain big biopsies. At the same time, some issue related to the doctor reimbursement. But if the patient is willing to undergo it, and that study was high quality, then no more screening is recommended. But if Barrett is detected at the time of the endoscopy, then there should be a very high quality examination to assess the mucosa very carefully, biopsy of any visible lesion, and it is now index procedure. So we start the examination by cleaning the mucosa and then looking at the G-junction, trying to identify the tip of the gastric fold, but we should avoid oversuppulation, which just spread the gastric fold and make it more difficult to detect. Those with dysplastic Barrett. However, the adherence to Seattle protocol is not very good, and community and university-based settings showed that the adherence rate can be down to 50%, and this does not appear to improve over time. Those with a higher length of Barrett esophagus, they have a higher risk of non-adherence to Seattle protocol, although we know that the higher the longer the Barrett, the higher the risk of detecting dysplastic lesion. Barrett time has been introduced back in 2012, and essentially the more you look, the more that you're going to detect this dysplastic lesion. And it is now in the ESG guideline that recommended at least a minimum of 1 minute inspection time for each 1 centimeter length of Barrett esophagus during surgery. These criteria, they have a very good correlation or inter-observer agreement among expert endoscopists, although it is not widely used to be compared to high-definition white light. In some studies, they have shown an incremental yield to detect dysplasia. It is now suggested to use chromoendoscopy in addition to high-definition white light when we do surveillance for Barrett esophagus. Dye-based chromoendoscopy using acetic acid has been also evaluated, and this met the BIFI criteria for adopting new technology. Drug-hit biopsy have a very similar yield compared to random biopsy with a much lower number of biopsy needed. Taken as needed. If there is a visible lesion, then we should use Barrett's classification to standardize the description of those lesions. And we know that some of the class like 0-1S and 0- compared to standard biopsy. And in a recent review, they concluded that the actual EGD done after detecting dysplasia on Watts then the aim should be to prevent Barrett esophagus progression and then to do surveillance to detect those who are going to progress. And then the patient get a risk score either low, intermediate, or high, and those with the high score has a higher odds ratio of progression compared to those with low risk. PIP score has been published in 2021, which included male gender, cigarette smoking, Barrett 1 point for each centimeter, and then confirmed low-grade dysplasia, and then the patient will get a risk score either high, intermediate, or low. This will determine the risk of progression per year, and the has been validated and recategorized into either low or high risk with maintained area under the curve, but we need more validation of this risk score, which has limited value beyond confirmed low-grade dysplasia for detecting the risk of progression. Evaluated as well, and it has been mainly focused to detect dysplasia, but some newer study has looked at the use of AI in characterizing dysplastic lesion. This is one of the largest study about using AI in Barrett esophagus by expert endoscopists, and that's what really we have been seeing with all AI studies. So it could be a tool to assist those with no expertise in Barrett to improve their dysplasia detection rate. Finally, this is the guideline for the interval of surveillance. So in those with short segment Barrett esophagus, less than 3 centimeter, then they should have a repeat surveillance in 5 years, provided that they have a high quality examination at baseline. If the Barrett is longer than 3 centimeter, then surveillance should be repeated in 3 years according to the ACG guidelines. The ESGE guidelines categorize those patients into those with higher than or longer than 10 centimeter, in which they should be referred to Barrett Esophagus Center of Excellence, or if their length is between 3 to 10, then they should have a surveillance repeated in 3 years. So in summary, the diagnosis of Barrett esophagus required at least 1 centimeter of columnar lined esophagus in association with intestinal metaplasia on biopsy. Case finding should be considered in patients with multiple risk factors, High-quality examination should be performed, identifying anatomical landmarks, Barrett esophageal extent, and that used Barrett Brack classification with photo documentation. Seattle biopsy protocol should be followed in addition to targeted biopsy of any visible lesion. Examination should be performed with both high endoscopy for detect dysplasia with adequate inspection time, and PPI once daily is recommended to prevent progression in those with Barrett esophagus, and we have to have a better risk prediction for those with non-dysplastic Barrett so we can stratify their surveillance need. Thank you.